mobile phone state of layperson for CPR without a hospital cardiac arrest. Definition: bystander induced cardiopulmonary resuscitation before the arrival of emergency medical service personnel in association with a rate of survival among patients with hospital cardiac arrest that is up to 3 times as wide as the rate among patients who do not receive such assistance.
Many persons who have out-of-hospital cardiac arrest suffer anoxic brain damage and may require constant care at home or in nursing homes. Owing to bystander CPR and defibrillation and to improvements in post-resuscitation care, there has been increasing survival after out-of-hospital cardiac arrest. However, little is known about long-term functional outcomes beyond survival and how bystander interventions influence these outcomes. Investigators used data from the Danish Cardiac Arrest Registry from 2001 to 2012 and found that of 34,459 eligible persons with out-of-hospital cardiac arrest for whom resuscitation was attempted, 2,855 survived to 30 days. The proportion of 30-day survivors increased from 3.9% to 12.4% over the study period. In 1 year of follow-up of the 30-day survivors, 276 died, and 300 were diagnosed with anoxic brain injury or admitted to a nursing home. For arrests not witnessed by emergency medical service personnel, bystander CPR increased from 66.7% to 80.6% between 2001 and 2012. As compared with no bystander resuscitation, bystander CPR and defibrillation were both associated with a significantly lower risk of anoxic brain injury or nursing home admission, with adjusted hazard ratios of 0.62 and 0.45 respectively. The authors conclude that bystander interventions were associated with significantly lower risks of brain damage or nursing home admission and of all-cause mortality than no bystander resuscitation. Full study results are available at nejm.org.
Application is nursing. With the use of a mobile phone resuscitation system, person without mobile phone can be located and sent to assist patients with some out-of-hospital cardiac arrest. This approach has been reported in prior pilots and simulation studies.
Hi, I'm John Tobin. I'm the EMS captain for the Mesa Fire and Medical Department. I want to talk to you a little bit today about what we've done for our out-of-hospital cardiac arrest resuscitation program. When we started out, we were, in the state of Arizona, we were saving about 3% of the people due to cardiac arrest. And that wasn't good for anybody. So what we decided to do was implement a state-advised program of hands-only CPR, and that dramatically increased our save rates to about the 26% rate for witness VFib. In the spring of 2010, we entered into a project with the University of Arizona, the Zoll Corporation, and the Arizona Department of Health Services, and we were intending to improve our cardiac arrest survival rates. And we did that in kind of a three-pronged approach. We talked to our members. We talked to our members and trained them very intently on high-quality CPR and what that means. We talked to them about the rate was very important, the compression depth was very important, and the amount of time that they're on the chest was very, very important. We also incorporated the PIC crew method. And then the third thing that we used is real-time feedback for CPR. So we have a dashboard on our E-Series Zoll monitors that we use to see exactly what we're doing. We showed that we had dramatic improvements by using those three things. We more than doubled our survival rates to discharge, and we more than doubled our rates to survival for a CPC score of a 1 or a 2. We're at about the 56% survival to discharge rate, which is really, really good. But what we're shooting for is 75% of witness VFib arrests. And that's kind of our mindset out there, is we always want to continue to improve. Some of the methods that we have done so much training with our responding crews that a lot of the things that we need to do now is beef up the rest of the chain of survival. So what we have done is we have implemented a dispatch-assisted CPR program that instituted the American Heart Association's 2012 guidelines for dispatch centers. We implemented the two-question model, is the patient conscious now, and are they breathing normally? And then immediately entering into CPR instructions. Another avenue that we're doing right now is we're beefing up our public access defibrillator program. We're putting them in every single city building, and we've evaluated every building to see if they actually need more than one pad device. So hopefully we're going to inch and inch and inch, just keep pushing that envelope, just keep pushing a little bit and keep improving.